So I'll introduce you. So Dr. Daly, it's great to have you with us. I'm going to call you Dr. Daly. You are an infectious disease doctor and professor in the Department of Medicine at the Department of Microbiology and Immunology at Albert Einstein College of Medicine in the Bronx, New York City. You study the parasite that causes malaria, and you've been working on a study for many years taking place in Malawi in East Africa. You also see patients at Montefiore Hospital in the Bronx. You did your residency here in Boston, where you trained other doctors who live and work nearby. So we're living through this tough time, and there are events happening around us, some of which we don't really recognize. There's a lot of fear, there's a lot of concern, but I've asked you to talk to us today to help us clarify some of what's happening and also to inject some hope into what's going on given your very current work. But let's go back just a little bit to your background with malaria and tell us just briefly, what is malaria, how is it transmitted, and who suffers from malaria?
Thanks, Roger, and I'm so happy to be with your class. I've done this before, and I'm sorry to not actually see people, but I'm really, really pleased to be here. So I became interested in malaria when I was pretty young in medical school, and malaria is a major global health problem, particularly affects poor people, and it is been with humans probably for 10,000 years. And this thing is transmitted by a mosquito. Female Anopheles mosquitoes take blood so they can make eggs. And while they're taking a blood meal for their eggs, they are accidentally injecting a malaria parasite into our blood. It goes to the liver rapidly. No one quite knows how it knows to get there. And for falciparum, which is one of 5 human malarias and the one that's fatal, spends about 2 weeks in the liver, undergoes incredible replication, and you have no symptoms. And then it comes out of the liver and starts infecting our red cells, which is kind of brilliant. It invades the red cells, it lives inside the red cells, it kind of hides in there, and it digests and uses the nutrients of the red cell. This is the stage that we get sick, because every 48 hours, the parasite ruptures the red cell and invades another red cell. And every time it ruptures, there's these foreign proteins, which are the parasite proteins, and our immune system recognizes that they're foreign. And we get fevers, we get cytokine responses, which are soluble mediators. Our B cells and T cells are evaluating this antigen to help develop immunity. And so patients can go on to either control the infection because they have immunity, meaning they were previously exposed, now they have antibodies and B and T cell responses, or if they've never seen it before, they will go on to overwhelming infection. The good news is we have lots of great therapies for malaria. So if I ever see a traveler who comes back with malaria, I can diagnose it very quickly. I do a blood smear and look under the microscope, probably like you guys do, and we can actually see the parasites, and then I can treat them with an anti-malarial. And so my interest in malaria has to do with a very special set of patients with malaria. In severe disease, you can go on and get coma. You can fall asleep with falciparum, and nobody really knows, why do you fall asleep? How come? You're having a seizure? Is it some sort of neurotoxin? And then if you treat these children, they wake up and they live happily ever after. So that's been my interest, Roger, since 1999. And I've had the fantastic fortune of working with people in Malawi, Terry Taylor, Carl Seidel, who are at Michigan State University and have a project in Blantyre, Malawi. And to this day, Roger, I am working with them. As a matter of fact, I was on a call this morning with them to look at some data. And so that's what I'm super passionate about. I'm also a general infectious disease doctor in the Bronx. And COVID is now upon us. So now I'm really full-time focusing on that effort.
Okay. Just briefly, before we get to COVID-19, what are some of the key factors in transmission of malaria or infection? What are the major factors that lead people to get sick?
Right. So I think the major factor is I'm exposed to malaria vector, which is the Anopheles mosquito. So bed nets will prevent the infection. In places that are a little bit more developed, we put screens in the house. And then in terms of becoming ill, basically everybody is going to get sick unless they have immunity. But as you're born and raised and develop immunity in maybe a village in Africa or India or Brazil, you actually have no symptoms at all. You're feeling completely well, and you do have the parasite in your blood. And ironically, even though you feel well, you're actually a reservoir, because the only host for malaria is humans. So Anopheles mosquito comes, feeds on an immune adult who happens to be carrying the parasite. Then they will then feed on another person, I think within a week or so, or 2 weeks, and then they infect a susceptible person, which is a young person without immunity, or perhaps a traveler. So those are sort of the factors that result in disease. Sickle cell disease, which is probably one of the first human polymorphisms that was well described, actually arose in folks who were facing malaria. And these mutations occur accidentally, but if they provide a survival advantage, they are then expanded. So if you happen to have a sickle cell mutation, it seems that you're protected from dying, and thus you survive. You have children who have sickle cell, and that's sort of why sickle cell mutation has sort of spread within the community, and it actually offers survival against malaria. The downside to sickle cell is if you get a gene from mom and dad, you can actually get sickle cell disease. So there's this really interesting dynamic between the parasite, our own human DNA, selection, evolution, and of course poverty. Poverty is the biggest risk factor for not doing well. If you don't have a healthcare clinic nearby, if you don't have medications. So probably the most important factor, Roger, now that we're talking about it, is probably access to care and poverty, which is something we can fix.
Right. So absent bed nets and screens and a more robust health system, things like standing water, and I've read maybe deforestation might increase those pools of water where mosquitoes breed. There's certainly emphasis both on the control side, controlling those factors, as well as the care side for those that are sick. And I'm just wondering, as someone who's both a physician and a scientist, do you find that you're somewhat, or people in your field are sort of torn between emphasizing more of the control or prevention versus resources that should go directly to care?
Right, I think it's a good question. I think at the end of the day, the best public health intervention is a vaccine. And it's worked for so many other diseases: polio, smallpox, measles, mumps, rubella. So I think having the basic scientists work on the vaccine for the ultimate really cure for this. We are getting some drug resistance. We have to develop new drugs. So I think, Roger, we need both arms. We need money to take care of people in our community who are ill with it, but we do need money for these other things to decrease your risk of infection. And then, God willing, coming up with, something like a vaccine that will prevent disease. Now, I will say, Roger, that this parasite has been with us for 10,000 years. It is, every time you're infected, we make antibodies, and the parasite, and generally parasites know this. So what they do is every time they replicate, they slightly change their proteins. So let's say an antibody sees a certain protein sequence, it will clear that parasite, but then the next parasite may come in with a different, let's say, coat, wearing a different color coat, and you need now a new antibody. So that's why the vaccine's been hard to make. It has to do with this antigenic diversity that malaria and other parasites have, and that, of course, is the big problem with HIV. Every HIV infection has a very different genetic sequence, and so that's why it's hard to make a vaccine against one sequence, when in fact that pathogen has many, many different types of sequences in the population.
Okay, got it. I want to come back to that sort of dilemma between control and care that was certainly relevant to healthcare givers in West Africa during Ebola as well. But let's jump to the present. So in addition to many of the demands that you have, both as a scientist and as a physician, you mentioned to me recently that you also became an advisor to a Jewish community in New Rochelle in New York, in Westchester County, where there was an outbreak, one of the earlier outbreaks in United States, I think, just about 10 miles from where you teach in the Bronx. So tell us about your work on COVID-19 in the past few weeks and how it relates to things in New Rochelle and what do you hope to achieve as you're going forward?
Okay, thank you, Roger. Well, I love working with basic scientists. I'm a physician. I know what we need. So 4 years ago, I started working with basic scientists who are able to make monoclonal antibodies against viruses for which I have no therapy. Ebola is an example. So this group of scientists studied patients who recovered from Ebola, studied their B cells, and figured out which antibodies they made were able to neutralize the virus. It's called like reverse vaccinology. Believe it or not, they can single cell sort B cells, pull out the B cells that react to the virus, clone the VDJ, make an antibody, and then test it. So I've been working with them for a couple of years as sort of a viral hunter, and we were looking for things like chikungunya, which causes arthritis, because we have no treatment. So we got some patients with chikungunya, and they developed monoclonal antibodies. And there's some other unusual arboviruses like Powassan, which we have no therapy. So I would find patients for them, get them their B cells, and they would then develop a monoclonal. And so that's been going along for 4 years. I'm always looking for a new virus for them. And then, of course, COVID came into town. And COVID is a RNA virus that seems to come from bats. And we had the first SARS virus in about 2002, if you remember that. It came out of bats, went into cats, and then the cats had interaction with humans, and it took off. And it's a thing called a coronavirus. The actual virus is called SARS, and that took off like wildfire. People got pneumonia, there was a lot of mortality, but it was quickly snuffed out. And so that was good news. And then a few years later, there was something called MERS, M-E-R-S, also a coronavirus, also starting in bats. And then it went into camels, and then people were in contact with camels, and they got MERS. Again, that seemed to snuff out pretty well. Caused a pneumonia, caused some mortality, snuffed out. And then, probably in November, this new virus that looks just like SARS-1, so it's called SARS-2 or SARS-CoV-2, started causing pneumonia and illness and fatalities in China. And we started getting reports in January. I think there was some misinterpretation, I think at the beginning. There was public health officials that thought the only people that could transmit had symptoms. And of course, that's very wrong. Actually, people could be completely well and transmitting. And that's important because if you're a public health person, you want to shut down the sequence of transmission. You want to quarantine people. And so that was sort of not understood. And then the other part that's really hampered our program is having a test. The key public health thing for anything is counting. Where's the disease? Where's the malaria? Where's the Ebola? And then swoop in, quarantine, provide care. But in the United States, we really don't have tests. As a matter of fact, most people haven't been tested even now that have symptoms. So what happened in New Rochelle was, again, the United States thought we're completely protected because we're America. And then all of a sudden, there was this outbreak in New Rochelle, which is about half an hour from the Bronx. And people in one congregation or synagogue all became infected. And so it was sort of the biggest cluster in the United States. The good news was a lot of public health people came in. They tested everybody like multiple times. They put quarantine in place. And in fact, they really controlled the disease, the infection. And so that's pretty awesome. And then, of course, it's completely taken over New York, which we can talk about more. But the project I want to tell you about, Roger, is one way that we could possibly treat patients is by looking or using the antibodies from people who recovered to treat patients with acute illness. So we talked about, maybe we didn't, but vaccines result in you getting antibodies, measles, mumps, rubella. Those antibodies protect you from measles, mumps, rubella. If you have a natural infection, you make antibodies. So there was some data from the original SARS epidemic, Roger, where they tested giving people It's called convalescent plasma, meaning it's the liquid part of my blood. It's full of antibodies because I just recovered from COVID, and giving that to acutely ill patients. And it looked like they had improvement in oxygenation, clinical improvement, and a trend towards higher survival. So now fast forward 10 years later, that was in 2003, we want to do the same thing. So the Young Israel Synagogue of New Rochelle reached out to Montefiore Medical Center, that's our hospital in the Bronx, said, hey guys, we are all better. We know we have antibodies, and we want you to come and screen us to see if we could be the donors. So I've been up there this week and basically have met everybody, and I'm screening them by measuring the amount of antibody in their blood. And if they have high antibody and they're otherwise healthy, they could donate plasma. And I didn't tell you this, Roger, but I was up in Muncie last night, and I was with a Hasidic community, and I think I screened like 70 people. So their epidemic is a little bit ahead. So that means at this point they have good antibodies. So I think my full-time job now, Roger, is just finding everybody who's been cured or, resolved their COVID and seeing if I can get their plasma so we can give it to our patients at Montefiore.
Mm-hmm. And how are you testing?
So believe it or not, there's still no FDA-approved test to measure the antibody level. Again, I think a failing of our public health officials. But Kartik, who I'm working with on this research project, he can actually measure antibodies. So he's developed his own assay. So Kartik and his team, and there's about 20 of them, I come back at night, and they're going to measure them using an ELISA. And so based on their antibody titer from Kartik, we can send them to the New York Blood Center, who will do the blood donation. And I think it's a perfect example of this basic science group being next to like physicians. This is like magic. This is exactly what you want to happen. Basic scientists with clinicians, and because I could never develop this test, clinicians could not do it. So we're really lucky in that way.
Yeah. And just briefly, I think you have a little bit of a story about bringing people to the hospital as well for the testing, or has that changed a little bit?
We basically don't want to bring anyone near the hospital because the hospitals are like chock full of active COVID. So basically I'm going up to communities, and then Roger, we're going to start screening people here, but we'll make sure it's like a clinic that's away from the hospital.
Okay, so outside the hospital. And just briefly about that community in New Rochelle and Muncie, and where there are sort of large concentrations of Hasidic or Orthodox Jews, they were in the news really just almost precisely a year ago around the anti-vax kind of discourse that was going on, and were often identified as an anti-vax community, a community that was resistant to getting the measles vaccine. Was that an accurate description? And just ironically, members of that same community now are coming forward to help us with the therapies to address COVID. So maybe just kind of bring that story full circle.
Right. So this was a big issue in New York. Measles is a disease for which we've had vaccines. People no longer remember that measles can result in brain damage and death. And then, I don't know why, but over the last 10 years, there's a group of people that are pushing that vaccines are all bad. And the fact is they're making money off of it. People are donating, they're making livings, they're giving talks. Because the data is, completely clear that vaccines have given life. And so they targeted the Hasidic community. They completely targeted them. They printed up pamphlets. They called them on the phone. So they were complete victims of the anti-vax campaign. And Roger, as you know, there are many different Hasidic communities. Yeah. They have different leadership. They have different groups of people. So there were plenty of Orthodox Hasidic communities that right away knew, of course, we should be vaccinating everybody. And the one in, I think, Williamsburg, because of this anti-vax targeting, did not vaccinate, or maybe there was less vaccination. So they're one of many groups. Most groups, of course, got vaccinated. They know the data. They weren't as targeted. And so I agree with you. I think the Hasidic group got bad press. Everyone thinks it's them. But the true truth is they were targeted with, I'm serious, phone calls, books. I've seen them. And so, you know, what's happening now doesn't surprise me. I mean, these communities are incredibly generous. This is part of their religion and culture and who they are. And if this changes the narrative a little bit, so be it. But for me, you know, I'm not surprised, and I'm just so happy that they're willing to do this.
Yeah, just one question I have and one observation is I wonder first if we'll have a turnaround around, you know, if the anti-vax community will be somewhat pushed aside after what we're experiencing now globally and the, you know, absolute race for a new vaccine and its importance. But one of the things I'm asking students to look at as well during this period is the idea of othering or exoticizing other communities that seem, you know, somehow different, and then displacing blame for what's happening on those communities that may be vulnerable because of being an ethnic, religious, national minority of some sort. And so I wonder a little bit if, you know, that narrative fouls with what was being thrown at the Hasidic communities just outside of New York City. So I want to come back to that question of control and prevention versus care. I think something like 15% of the caregivers in West Africa in the maybe 2015 outbreak, or maybe it was the 2019 outbreak, but some very high percentage of the people who got sick with Ebola were caregivers. And now we are just inundated with news about how our caregivers, our physicians, our nurses, our other healthcare workers, first responders, EMT folks are really on the front line and are at much greater risk than the average population. And I wonder if you could just talk a little bit about that, both where you see the emphasis here in the United States, say in the last several weeks. Has it been more on control, and have we neglected once again the caregivers and treating them who are putting so much at risk for all of us?
I totally agree. I mean, we're having healthcare workers who are, I mean, amazing that people go to work every day. Everyone is getting infected, even though we all wear protective gear. Personally, I think convalescent plasma to healthcare workers should be prioritized. We are slightly in crisis in terms of running out of gear. I think we have like a day's left, although our governor keeps trying to get more masks in and this sort of thing. We're definitely reusing things. Mm-hmm. So we're sort of slightly at a crisis level with that. I mean, they're getting a lot of press. I think people are donating, you know, but we are running out of things. It's weeks. I don't know how we're going to fix that, except every day. I mean, I can tell you the leadership are spending all day trying to get supplies for us.
The leadership at your hospital.
Yeah, so they're, you know, people realize how important, and every day they're just spending all day long trying to get donations, trying to get things done. I think for the rest of the country, if it does spread, maybe everybody by that point can gear up, like get enough masks, maybe people could shelter in place. New York did not shelter in place until this thing was way underway. So I'm hoping the rest of the country has less of a hit.
Yeah. And I don't know if you've had much time besides, you know, your work to sort of evaluate a little bit of how other countries addressed COVID-19. But I'm wondering if you observed any differences in that sort of control versus care, dilemma, how that played out in, say, China or Italy and South Korea. I mean, did you see a different equation in what you've been able to discern from the news?
I think it's so hard to know what's going on in Europe. I mean, I think it's so hard to know what's going on everywhere. I only know what's going on here. Yeah. Except to say, I think the United States didn't recognize, I think some people definitely recognized it was coming. I think other cities will see what's going on here. But I think, Roger, at the end of this, is going to be years of study and all the aftermath. And I'm hoping that we'll have a better response. But remember, we had a pandemic task force. It was in place by the Obama administration, and it was disassembled in 2018. So this is typical human behavior. We forget. We go through a tragedy, we say we're going to do things differently, and then we forget, we want to save money. So whether we'll remember longer, I think we will. So maybe we'll have a proper task force that won't be disassembled.
Yeah, I mean, the genetic sequence for the novel coronavirus was published in China on I think it was January 10th, I think it was.
Exactly.
And, Wuhan was locked down just shortly after that. You mentioned that we forget as a society that there's been many systems to draw on that we could have put in place. Certainly the public health and scientific community has been amplifying, and emergency management people have been amplifying these messages for years. I mean, do you see any of the lessons kind of kicking in now, or are we still kind of, operating like it's January? And
I'm hoping the rest of the country is operating differently. In New York, we're now just at the crisis, and now it's just, we can't prevent it anymore, and we don't have a treatment. So again, I think it's going to be up to other communities, and I think other communities will have will do a better job.
I have one more question, then I want to go to some of the questions that students and family members submitted, but you just let me know if you have to leave. I'd like you to talk a little bit about what you're hopeful about, and maybe what other therapies are out there. What have you seen among New Yorkers that gives you hope and inspiration?
Well, definitely my donors. I mean, I've had like 3 great days with people who are just wonderful, and I've sort of just immersed in their community, and I'm taking their blood. It's very personal. I'm asking their medical history. It's very personal. So that has been like extraordinary, and I wish everybody else get a chance to participate in that. The residents and the healthcare workers, everybody wants to donate. People still have a sense of humor, and people are going to work every day. They're taking extra shifts. So people are really awesome under the crisis. There's a threat to their own health, and they're like, everyone's doing it. I haven't really heard much of people saying, I'm not going to go in or whatever. People are volunteering. So this is like extraordinary times, and people are really stepping up in a way that kind of blows your mind. So that's been really awesome. Day-to-day life, people aren't asked to step up like this, so you don't see it. So I think we're seeing that, and that's pretty exciting. But it's in contrast to a lot of, suffering and that sort of thing.
Yeah, someone who studies and teaches history, I mean, the last time we were really asked nationally to stand together and step up and engage in some form of sacrifice, of course, was World War II. We fought many wars since then. We've had other threats. And I just wonder if some of the lag and some of the resistance by leaders to ask more of us, which might be as simple as social distancing. We just saw the governor of Florida, today's April 3rd, just saw the governor of Florida finally ask people to really, retreat from public life, from the beaches, et cetera, where there was an elderly population, where there's high rates of cases. I just wonder if some of that, there just seems to be baked into our culture now, a very different response than we had to World War II, which was to not ask us to do anything. I'm hoping that's a lesson we'll learn. I want to just transition a little bit to a couple questions, if you have time, from some students and family members. One was, do you have any opinion about the studies that suggest that hydroxychloroquine therapy, which is also used in malaria treatment, so also part of your expertise, may be effective at treating moderate cases of COVID-19? And what are the ethics of redirecting the drug away from patients with chronic illnesses like lupus, which I guess that is a therapy for? At one point, the president mentioned chloroquine, go use it. What's happening on that front?
Right. So Roger, like almost everything we're doing, there's zero data.
Mhm.
So if you grow this virus in a tissue culture and you add these various drugs, you inhibit it, but that is a long way from going into an animal and testing it, and certainly a human. I'm looking up now to see if there's any data on chloroquine. I can tell you everybody at Monty is getting it when they come in the door. But I don't know of any data. There was one paper on it, but I think it wasn't very well designed. They didn't really have the endpoints clearly described. And the only way to know, and this is probably the most important thing for your class, is that everything that we do in medicine should be with a scientific basis. And the way you do it is give one group a control or a placebo and another group the thing that you think works. And you do it blinded, you do it randomized, and then you see if it works. And that's how every drug in this country gets approved under the FDA, by doing that. So your guess is as good as mine. Do I think the death rate's dropping, or the death rate would have been worse? Hard to say. We really don't have that data. Maybe we can go back and compare patients who didn't get it versus those who did, but like at my hospital, everyone got it. And then this idea that we should restrict it from one group to give it to another, that's like, I don't know how important that is. I don't even know if this drug works. I think a lot of people have gone to hydroxychloroquine. I guess if there was good data, Roger, that this is like really working, then yeah, we could say, let's stockpile it. But I think it's a minor concern, saying that some patients shouldn't get it, some should. But I think the most important point is we really need data, and
Sure.
so many patients, Roger, we could have done it in 2 weeks.
Is there an ethical concern though about, and again, I don't know anything about this. Actually, your guess is much better than mine. But is it taking that drug off the shelves for people that rely on it for non-COVID-19 illness? Are we now denying that population access to that drug by offering this to people that walk in the door at your hospital and others?
That's hard to say. If I had really bad autoimmune disease and this controlled my symptoms, withholding that from somebody versus using that as a complete guess in other patients, I don't know about that. So maybe you could say, well, let's see who really needs it. Again, I think the answer is to make more chloroquine or hydroxychloroquine. So I think the energy into that question is, maybe there's too much energy into that question. But I guess that's the way you could go about it. Like if there was really evidence that Plaquenil was saving lives, then fine. You could go back to your patients who are using it and see if there's an alternative drug. But that's not going to be that many patients, I think. Mm-hmm. And I would say instead, let's go to that manufacturer, say, hey guys and gals, can we triple our dose of Plaquenil?
Yeah. Another question from someone was about vaccine. Should it be developed in the next 12 months? And just to clarify for some of the students, vaccine takes a long time. There's got to be clinical trials. Both, you're going to be able to ramp it up in a large clinical trial, and then there's the production side as well. But this person asked, should a vaccine be developed in the next 12 months? A few questions come to mind. Given the problems that arose in the wake of the 1976 swine flu vaccine, i.e. increased incidence of Guillain-Barré syndrome, how will scientists determine when a vaccine is safe to administer? That is, what's the balance between the potential societal benefit versus harm to an individual who may not respond well to that vaccine?
So say again about the vaccine, sorry?
Just asking really about the, how we know if a vaccine comes to market really quickly, say in the next 12 months, how do we know when it's safe to administer to the general population for a larger societal benefit versus being concerned about the harm it may cause certain individuals who don't respond well to that vaccine?
Right. So, all therapeutics go through these incredibly rigorous phase 1 for safety, phase 2, dose finding, safety, phase 3, efficacy, phase 4, larger efficacy studies. So everything is incredibly rigorous. The FDA, this is a real professional organization. It takes millions of dollars to get, they say it's $1 billion to get one new drug to market because you study it in people and you measure everything you can think of. So once the vaccine goes through these phases, and they may try to go a little faster, you then have to ask yourself, maybe there's some adverse events. So you have to weigh out what is the risk of not taking the vaccine and getting COVID versus taking a vaccine, being protected from COVID, but maybe risking a side effect. Maybe you get a little redness in the arm, maybe you get a little fever. But the idea that you're going to get some fantastical side effect from a vaccine there's really no evidence for that. And that's part of what's driven these anti-vaxxers. They're saying it causes autism, and there's no data for that at all. People have looked incredibly carefully. So I think it's a risk benefit, Roger. And when people ask me now about COVID, should I meet my children or not? I say, look at the guidelines. A lot of people thought deeply about guidelines. And then if there's room within the guidelines, you make your own assessment of risk benefit. In terms of vaccines, the one thing about a vaccine is not only my health, but is whether it's going to help me have my community. So sometimes we want everybody in the community to be vaccinated because then we won't have epidemics. And that's like a different issue. It's no longer just me and my health and my risk benefit, but should my entire community have to have that vaccine? And for most vaccines, this has never been an issue. And again, we don't have a memory of the horrors of polio, measles, mumps, rubella to remind us. So I think if someone comes out with a COVID vaccine, I'm definitely taking it because people are could have a bad outcome, even though most people who get infected do well. And yes, I mean, these things will be safe. Trust me, they're not going to put a vaccine out half tested and unsafe. And they know how to do it. So I feel really confident on that side of it. Mm-hmm. Whether Roger will get one in place by the time, we might get one in place when this thing is over. Whether COVID-19 will come back again next year, that would be good if it does. We don't know if it's coming back next year. Maybe there'll be a COVID-20. Yeah. So a lot needs to be figured out.
And should it be, if a vaccine does come on board in a year, I mean, should it be compulsory for people, do you think, to re-enter group activity? I think around measles last year, if I remember correctly, the governor had mandated vaccination around measles.
Yeah, I mean, it's just like common sense. It's public health. It's how we've eradicated smallpox and polio. I don't know, and again, I think it's these anti-vaxxers that it's like the fake news that's going on in every area. And unfortunately, it's now affecting people's health. I don't know how to combat anti-vaxxers and fake news on any level. What I do recommend for people is, and this is what I do, like I go to the guidelines. I go to WHO guidelines, I go to CDC. Those are trusted expert sources. But why people don't want to use scientific evidence, or why people, maybe there's a draw in the human nature to be drawn towards conspiracy. That's much more exciting than reading the boring CDC guidelines. But I don't know about that. But my response is, hey, let's look at the guidelines if you have a question. And, we can't force people to do things. And I think it's part of human nature. Maybe there's something good about that in our genetics.
Yeah. Last question. How are you feeling? How does it look when you come into work every day, and how do you, deal with it emotionally, intellectually?
Yeah, I think it's hard to sleep at night. I mean, I'm slightly protected because I'm doing this, what feels like a very positive thing, enrolling people who recovered. I will probably be on the wards in the next few weeks, but for now, I'm just working on the clinical trial protocols, these protocols. So I feel like I'm in a little bubble. I'm really happy in my little bubble, but I also know what's going on right across the street. So that's why I want to work even harder. If I can get this convalescent plasma, this is something we can do for our patients that's real. So I'm super duper motivated for this project.
Mm-hmm. Well, not only thanks for talking to us, but thanks especially for working so hard for all of us. And we are, share your optimism and excitement and just appreciate everything. So thank you so much.
Thanks, Roger, and good luck to all your students. There's nothing you guys can't do. There's nothing you guys can't, fight in the future. Just get a great education, use your head, talk to each other, be creative. It's going to be fun.
All right. Thanks so much.
Take care.
All right. Take care. Bye-bye.
Bye.